Good evening to all the viewers who are watching live and who will be watching while on the recorded version. It is required to just let you know that currently we are not having any winners for today's CME, and we are sorry for that since we are having some technical issues with our IT team. So that's why we are just facing with different kind of stuff. So pardon us for that. So without wasting any more time, let's just jump to the greatest, a few of the greatest topics of our series after the 30 seconds countdown time.
Good evening, everybody. Good evening, sir.
Good evening. Very good evening to all.
Tonight, starting from lockdown stage and till date, we had come across 44 live online continued medical education programs, and today we are having the 45th chapter. And tonight, to start with our program, we are blessed and we are honored to have with us, with the permission of our President Kalyani, sir, please.
Sure. Let us start.
Uh, yeah, let us start. And I'd like to request respected Madam Mousumi Halder, our librarian and information technology in charge of National Institute of Homeopathy, to inaugurate tonight's program. And also, we are eager to hear from ma'am about the great NH library. I'll request our backstage editor, Orko, to bring on screen, madam.
Hi, I am Mousumi Halder, librarian in charge of National Institute of Homeopathy. First of all, I am honored to be the inaugurator of the 45th CME of National Institute of Homeopathy Alumni Association. Thanks to the association for choosing me as inaugurator. CME is a platform of mixing the knowledge on homeopathy among the homeopaths. It helps to enhance the knowledge among the homeopathy fraternity. It is a very good news that NIH Alumni Association achieved 44 successful CME program. I hope that the association may arrange more such successful CME program. Now, in today's CME program, moderator is Dr. Sukhendu Sarkar, Professor and Head of the Department of Organon of Medicine, Pratap Chandra Memorial Homeopathic Medical College and Hospital. Speakers are Dr. Taha Khan, Director and Co-founder of SZ Hospital Private Limited and founder of Pulse Coaching Institute. His topic is treat 80% cases of piles with 100% accuracy. And another speaker is Dr. Ghulam Wani, Senior Medical Officer, Homeopathy, Union Territory of Jammu and Kashmir. His topic is Vitiligo and its homeopathic management. Now I am telling something about NIH library. Dr. Kalyani asked me to tell something. NIH library is a big library, no doubt, but for COVID situation, there was no purchase of books for few years, 2020 to 21. Now we are going to purchase of rupees 28 lakhs rupees books. We already ordered them, and they are coming. The books are coming, and 16 journals are subscribed yearly, and one archive is constituted by the donation of books by Dr. Mohendra Singh and Dr. M.M. Datta. The archive is now not working. It is not open now for all, but the work is going on, and soon it will open for general student. This is all. But now we are facing so much for staff lacking. There are no staff in library. Only 3 technical staff is there. The huge work is done by them. So staff lacking is a great problem for library. This is all. And now I am giving I am handing over to Dr. Sukhendu Sarkar, moderator.
Good evening, Sukhendu. Please unmute yourself. Thank you, Mousumi ma'am. Mousumi ma'am had been working tirelessly through and through for the vast collection of books which we have in our National Staff Homeopathic Library. And post-COVID, the library will be operative in full swing. Now, tonight's moderator, Professor Dr. Sukhendu Sarkar. Sukhendu, we are going through certain technical snags. Sukhendu, can you hear us? I think there is a technical issues on with Sukhendu. I'll get back to Sukhendu. Sukhendu, can you hear us? Sukhendu, can you hear us? I'll request Oko to bring on Kalyani sir on screen. And our tonight's first speaker. Our tonight's first speaker will be Dr. Sir, shall we start with Dr. Taha Khan or Dr. Ghulam Nabi Wani?
No, we can start with as it has been scheduled. Taha Khan may be called first.
Okay, over to you, Dr. Taha.
Okay, good evening, everyone. Thank you for this invitation on this CME. I think this is my first invitation. Let me just share this slide with you. Okay, so is it visible? I think this should be visible. Yeah, I think this is visible. Yeah, I can myself see it. Okay, so the topic, my topic of discussion is treat 80% cases of piles with 100% accuracy. Now, this is quite a different kind of topic and not a very straightforward topic. So, first of all, why piles? Why did I choose this topic? See, basically, there are 2 reasons for me to select this topic. The first reason being that I get a lot of piles cases. I get a lot of piles cases since I have started my clinic. And there are also reasons why I'm getting patients. Like if you search on Google best homeopathic doctor for piles, then chances are Google will show you my profile in the top 3 or in the top 5 lists. So that is one of the reasons that people are searching for piles on Google. That is also one take back from this seminar, that people are searching for homeopathy. People are preferring homeopathic treatment for piles. So that is one reason that I get a lot of piles cases in my clinic. And usually piles is so common these days because of the changing lifestyle that that is changing with time. As we know, okay, our lifestyles are changing, even our food habits are changing, our environment is changing, so all these has some effects on our health. And this is one thing, this piles disease is one thing that has a cause in its environment, in what we eat, in how we sleep, in our lifestyle. So that is one reason that I get lots of piles. And of course, like if you go through like every 3 to 4 comments, this has become so common that every 3 to 4 person is gonna suffer from piles at least once in their lifetime. So that has gone so common. And my second reason for selecting this topic that I was saying, this piles topic, is that patients nowadays prefer homeopathy treatment for piles, because you will get, when you are getting piles cases in your clinic, what I see, what I have felt is that patient had been advised, like they had been to previous doctors and they had been advised to go for operations. And patients don't prefer operations. Operation, going for a surgery, that is the last resolute. When everything else in the world has failed, then patient thinks about going for a surgery. But if a patient is suffering from piles and he is going to a doctor, then chances are the first thing that the doctor will advise to the patient is to go for surgery. So patient usually wants to avoid that. And so when patients are searching and they are seeing all the cases that has been cured by homeopathy, all the piles cases that has been cured by homeopathy, so patients prefer piles, so they come to the doctor, to the homeopathic doctor, for their piles treatment. So these were the reasons, these were the two major reasons actually why I wanted to have a discussion and I want to talk on this video, on this topic, this piles topic. And the next important thing is why 80%. Like if you read my topic, it's treat 80% cases of piles with 100% accuracy. Now why 80%? See, if like this video is being watched by a lot of seniors, my teachers, and also my juniors, and if you are watching a recorded version of this video, and if you have been following me, like I myself have a YouTube channel by the name of Dr. Tana. So if you have been following me, so there is this one thing that I have talked in the past also, and this thing really fascinates me, that this is just off topic. There is a thing called Pareto principle. There is a thing called Pareto principle. Now, this is a principle which says, this is also known as the 80-20 rule. This principle is also known by the name of 80-20 rule. Now, what does this principle say? This principle says that your 20% efforts will give you 80% results. 20% of your 80% of your results comes from 20% of the efforts that you put in. And this thing, if you even think yourself, this thing is applicable everywhere. It is applicable absolutely everywhere. Like if I say, you will see that in businesses, in big companies, they see that 80% of their profits comes from 20% of their products. And if you apply it in IT companies, they see that 80% of their crashes is happening due to 20% of the bugs that is in their system. And that is equally applicable to us also. We will also see that 80% of our income comes from 20% of the diseases that we treat. 80% of our income, or 80% of our, means a surgeon will see that 80% of his cases comes from the 80% of the income that he treats, 80% of his surgeries comes from 20% of the surgeries that he is doing, 20% of the surgeries that he is doing. So that is the Pareto principle that I am talking about. Now, having said that, this 80-20 rule, this is why I wanted to say that if you are able to treat 80% of piles cases, out of all the 100% of piles cases that is coming to your clinic, if I am successfully, with accuracy, I am able to treat 80% of those piles cases, then my clinic will flourish. And I will get more and more piles cases turning up in my clinic. Because to be successful, you just need to be 50% your cure rate, your actually success rate or your cure rate at least needs to be 50% only. Like if you are able to provide relief to 50% of the patient that is coming to your clinic will go on like booming. And even if I talk about individual cases, if you are able to give 50% relief to one patient, individual patient, then that patient will continue coming to you. So that is why I want all of you to focus that how to treat 80% of the piles cases that is coming to you with absolute success, where you will be successful in these 80% cases. Forget about the 20% cases, because there are few cases in not only in piles, in every disease, in in respiratory distress, in heart disease, hair fall, like whatever the disease, there will be certain disease that will absolutely be not curable by the best of the doctors in the world, not only homeopaths. So you don't need to focus your energy on those 20%. You just focus your energy on those 80% that will actually bring you the rest of the patients, that will actually bring you uh, your income. So let me change this slide. Yeah, so the definition now, for academic purpose, you can find these definitions on the internet also. Just for some person, because there might be few people who are not absolutely non-medical person who might be watching this video. I already know that almost all the medical person must be knowing what is piles, what piles is, what hemorrhoids are. These things, we medical persons, we know the definitions in and out. But for a non-medical person, just just understand that there are veins in our body that carries blood from one part to another, and these veins are elastic structures. So there might happen, like if there is an increased pressure, agar pressure बहुत ज़्यादा हो गया, if there is an increased pressure, so these veins might swell up. And since the veins are all over in our body, so veins are also in our rectum, also in our anus, also from the places where we pass stool. So if the veins actually swell up in the rectum, that is when we call piles, like varicose veins. Varicose veins are also swelling of piles, but that is happening in elsewhere of the body. But if the same thing is happening in the rectum, we will tell that okay, the patient is suffering from piles. Okay, so this is the basic, means non-medical to understand, non-medical understanding definition of piles. Next is, let us understand why does piles occur. Just a second. Yeah, next is let us understand why does piles occur. Now, why is this important for a doctor also to have a brief knowledge, to have a basic medical understanding of what is piles, why does it occur, how can you prevent it, and how bad is your piles? Because these are the things that patients will come and ask you in the clinic. Patients will come and ask you in the clinic, because piles patient, if you can assume that if a piles patient is coming to you, then you can assume that he has gone through the internet. The patient has already gone through the internet, he knows basic things about piles, and some patients have become expert in piles. So at least I expect and I believe everyone to have a basic medical knowledge of the common diseases. Just like I said, okay, you chalk out the 80% of the diseases, the common diseases that the patient that you are having in your clinic, that the common diseases that are coming into your clinic, and have a basic idea about that. So what are the basic causes of piles? Etiology means piles, causes. So what are the basic causes of piles? See, straining and constipation is the most important cause for piles, because what happens is when we strain, that causes more pressure in the veins, inside the veins, that causes swelling of the veins, and that may have a lot of consequences, like it may cause bleeding, it may cause pain, and many other things. So straining and constipation is one of the most important cause with which the patient will come to you. Second is pregnancy, because this is a physiological cause of piles, because a pregnant lady, during pregnancy, there is natural increase in the intra-abdominal pressure. There is increased pressure, which causes pressure in the rectum, because if there is a pressure intra-abdominally, that naturally will cause pressure in the rectum. And this pressure will again put pressure on the veins, which will lead to piles. And obesity is a thing that harbors a lot of diseases. Piles being one of them, hemorrhoids being one of them. Piles and hemorrhoids are same thing. Then the fourth cause is prolonged sitting. More and more sitting causes increased pressure at the bottom, which leads to piles. If you are suffering from any hypertension diseases like portal hypertension, if there is increased blood pressure, that may also lead to piles. If you are suffering from constipation, diarrhea, there might be a familial history. If there is a familial history, then also chances are you might suffer from piles. Moving on, there may be a colon malignancy. There may be a colon malignancy which causes bleeding, which causes pain. Of course, colon malignancy is a huge thing, but that may also cause piles. Loss of rectal muscle tone, that may also cause piles, and that if there is loss of rectal muscle tone, this actually causes a higher degree of piles, the third degree, the fourth degree of piles. This degree of piles will be coming in a minute, but that is actually what happens because the rectum is held by muscles in the body. Every organ in the body are attached to muscles. That is why they hang, they don't fall. So if the muscles get weak, then that organ will fall. So that is the this weakness in the rectal muscle is one of the causes of piles. Spinal cord injury, that may cause piles. Rectal surgery, if there has been a surgery in the past or there has been a surgery recently, then there might be the patient might have suffered from some injury during the surgery that has got piles. Then episiotomy, another cause of piles. IBD, these are all the causes of piles that you might get patient coming to you with these causes. So you just have a basic idea what are the causes of piles. Next. Okay, just understand this. Position for piles, you just remember three things. One is 3 o'clock, one is 7 o'clock, one is 11 o'clock. Just these three things. 3 o'clock, which is left lateral position, as you can see in the image. The 7 o'clock, which is the right posterior, and the 11 is the right anterior. Just remember these three things, that these three are the positions. Like if you are examining a patient, if you are going for an examination, then these three places are where you will be looking. Sorry. These three places are the positions where you will be looking for piles. Okay, so just know for basic understanding. And you can classify piles under two heads. One can be internal piles, and the second one can be external piles or external hemorrhoids, as we can see. Now, how do we classify this? Like, how has this classification been done? To understand this, you need to understand you just need to remember one thing, which is the dentate line. There is a line which goes by the name of dentate line, or other name of dentate line is pectinate line. So anything above that is internal, anything below that or beyond that is external. So as you can see in the image, there is one internal hemorrhoid, and this is the line of differentiation. I don't think that you are able to see my mouse, but the grayish lines area below that is the external, that is the dentate line. So anything below that, all blood vessels below that, if piles is occurring in those, I will say that okay, that the patient is suffering from external piles or external, that is the case of external piles. And if the swelling is above that line, above the dentate line, then I will say okay, the patient is suffering from internal hemorrhoids, or it is a case of internal hemorrhoids. This is the basic difference. Just one line you need to remember, dentate line. Absolutely one thing. Next. Now, of course, there are few differences. There are few differences between internal and external. One difference that I already said, that one is above the dentate line and the other one is below the dentate line. And for more knowledge, you can see the development and the covering. But you just need to remember, for clinical purpose, you need to remember two things. One is the dentate line, whether it is above the dentate line or whether it is below the dentate line, so you can classify whether it is internal hemorrhoids or whether it is external hemorrhoids. And the second thing is the nerve supply, and that is important for clinic also, because you see that the internal hemorrhoids is not supplied by any somatic nerves. The internal hemorrhoids is not supplied by any somatic nerves, whereas the external hemorrhoids, means the external, the beyond portion of the dentate line, is supplied by cutaneous nerves. So we can simply derive that if a portion has nerve supply, then that will be painful, and if a portion doesn't have any nerve supply, then that portion will not be painful. So we have patients. There will be patients coming into the clinic with pain, and there will be patients coming into the clinic without pain. So the patients that are coming there, of course, there are certain case conditions where even the internal hemorrhoids will become painful, and we'll be talking about that just in a while. But in general, the internal hemorrhoids are painless. So if a patient comes to us in the clinic, and if after examining or after finding out or after inquiring, we come to know that okay, the patient is not suffering from any pain, so we can assume initially that okay, this might be a case of internal hemorrhoids. And if the patient is saying that there is pain, any sort of pain, be it severe pain, light pain, whatever pain, if the patient is suffering from pain, then we can at least assume okay, so the patient is suffering, this might be a case of external hemorrhoids. Okay, so these are the basic differentiations of internal and external hemorrhoids. Okay, now why is this important to understand the levels or the stages of hemorrhoids? Because I think last week a patient came to my clinic. The patient is suffering from piles, and he is already under my treatment since few months. I think 3 to 4 weeks, and the patient was quite anxious to know whether it is a bad case of piles or whether it is a good case of piles, whether his piles will get cured early or will it take time. So I cannot simply tell the patient that the piles cases it is well treated by homeopathy, so it will get cured soon. Because I need to first understand whether it is what the piles is at what degree, it is at what grade piles it is. Then only I can say okay, so this will take time or this will not take time. This will get cured early. So I need to make that statement based on few judgments that I will derive from the patient. First of all, I need to understand what are the levels of hemorrhoids. See, first level is there is absolutely painless bleeding. There is painless bleeding and nothing else, which is a classical symptom of internal piles, that there is painless bleeding and nothing else. You will have a lot of patients coming with this particular symptom and only with grade 1 piles. That patient will say, doctor, I'm only having bleeding and nothing else. No pain, no itching, nothing else. Only when after passing the stool, I see few drops of blood on the toilet pan. That's all. That is the only symptom. So you know, okay, this is the first grade of piles. Means the piles has just started. Means the piles has just begun. So you know, you can tell now since you know this, since you have understood, okay, so since this is the only symptom, then probably the patient is having grade 1 piles. So I can confidently tell the patient, okay, don't worry. This is just initial phase of piles, and there is nothing to worry about, and your symptoms will go away quite quickly. Now this statement I can make very confidently. The second grade of piles is that there is prolapse. There will be prolapse on defecation. Means during stool there will be slight prolapse which resolves, which reduces spontaneously. Means I have to do nothing about that. The patient has to do nothing about that. There is bleeding, there is prolapse, and both bleeding and both prolapse goes away after the stool. Means the patient has to do nothing. So now I know, okay, in grade 2 of piles, the patient has bleeding plus prolapse, but both of them gets resolved after stool. There is nothing to worry about. Next is grade 3. Next is grade 3. In grade 3, there is bleeding, there is prolapse, and this prolapse has to be reduced manually. Means it won't go away. The prolapse won't get reduced on its own like it was happening in grade 2. So if a patient comes and says these things, that there is bleeding when I go to stool, and I feel something when I wash my anus, when I wash the rectum, when I use water, there are few things that I feel in my hand coming out. then see, patient is not gonna come and say to you that, okay, doctor, I am having bleeding and also I have prolapse and I have to reduce it manually. This is not the line, or this is not the language that patient is gonna use. Patient is gonna use, okay, I feel something coming up. So you need to understand, okay, the thing is coming out, whether that is getting reduced manually, means that gets reduced spontaneously, or that has to be reduced manually, or that doesn't get reduced at all. These three things that we need to know, then only we can decide whether it is grade 2, grade 3 or grade 4. So if it gets reduced spontaneously without any intervention, that is grade 2. If that gets reduced manually, means the patient has to do something to remove it, that is grade 3. And whatever you do, it won't get reduced, that is grade 4. Grade 4 is whatever you do, that prolapse rectum is not going to go back. That is grade 4. So after having this basic knowledge of grade 1, grade 2, grade 3, grade 4, I can now confidently tell a patient what degree his piles is, because patient will ask, okay, how bad is my piles? So now I can make a proper judgment how bad is the piles of the patient, that the patient is suffering from. So these were the levels of internal hemorrhoids. Next. Okay, now let us see few of the symptoms. Few symptoms of internal hemorrhoids. Now these are the symptoms, whatever symptoms I have mentioned here, these are the symptoms that you will get to hear in the clinic. These are not the symptoms from the books, because in books there are a lot of more symptoms than this. But these are the symptoms that you will get to hear in your clinic. First symptom is painless bleeding. That is, we know that this is a internal case of internal piles. Painless bleeding. How? The patient will say that after a stool there are few drops of blood falling on the toilet pan. That's all. Or there are few drops of blood on the tissue. That's all. That is painless bleeding. Okay. Second is, there is prolapse. Second symptom, that just as we were speaking, that patient will say that, doctor, after when I try to wash my stool, I feel something on my hand, on my fingertips. That is when we can know, okay, along with piles, the patient is also suffering from prolapse, and there might be pain and irritation. There might be pain and irritation. Okay, now, yeah, so the symptom that I was saying, acute pain, you can see that in the symptoms of internal hemorrhoids. Just now we were speaking that there are no nerves, right? There are no nerves in the above the dentate line. So how come internal hemorrhoids be painful? See, there are conditions where patient is suffering from internal hemorrhoids, but still the patient is saying that there is pain. There are few conditions under which this internal hemorrhoid becomes painful. For example, if there is a case of strangulated, if the piles becomes strangulated, then in that condition there will be irritation, there will be pain. So it's not a hard and fast rule that the internal hemorrhoids means absolutely no pain. That might be painful, but usually that is painless. Usually that is the usual thing. So three symptoms we have known for so far from piles that we are gonna hear in the clinic. One is bleeding. Second is pain. Third is prolapse. Okay, and the fourth symptom that we are gonna hear in the clinic is itching. There is perianal pruritus and irritation. In short, the patient will say that there is itching. That can be before stool, that can be after stool, that can be at any time. But these are the four symptoms that we are going to hear in the clinic: bleeding, prolapse, itching, and pain. These four symptoms. Remember these four symptoms for piles. Next. Okay, now there are two symptoms of external piles. External piles are painful. Usually, normally they are painful because we now know that they lie below the dentate line. So there are nerve supply to that portion. So now we know, okay, external hemorrhoids means that that will be painful. And the fifth symptom, four symptoms we have already studied. The fifth symptom is skin tags. this is one thing that patient will come and tell you, and this is one thing that you will have to differentiate between the fourth degree of piles that has gotten prolapsed and skin tags, because there are cases that you patient will say, and there are cases that you will find that the patient is suffering from piles and there are skin tags. Now this is one symptom that will take time to go, because this is a portion of the skin that lies around the anus and that has developed due to piles, but this thing will take some time to go. At least this is what I have observed. My if any one of you have um, if any one of you have treated cases of piles, then this might have been a rare observation to you, or you might have been able to cure this skin tag, this particular symptom that I am saying. This skin tag you might have been able to remove from the patient quite early, but this is what I have found, that all other symptoms, the pain, the bleeding, the itching, the prolapse, all these symptoms goes away first. All these symptoms are easy to remove, but this skin tag will take time. I don't know how much time it takes. It varies from patient to patient. But this skin tag, at least I tell to my patients that your symptoms will go, but the skin tag symptom that you are saying, this will take time. So you will have to continue the treatment for some time. Okay. So these are the symptoms of piles. Basically 5 symptoms in total. If I say, just remember: bleeding, pain, itching, prolapse, and skin tags. These are the 5 symptoms that I'm going to get to here in my clinic regarding when a patient comes to piles, regarding piles. Okay, now let's move on. Yeah, so there are few examinations that you as a doctor can do, or a surgeon, if you have advised the patient to go and have a check from the surgeon will do. So even you as a doctor can do few physical examinations to confirm whether this is a piles, what degree of piles, and which position of piles. Okay, so there are few examinations, like first of all is a digital examination. See, external hemorrhoids can be viewed from the outside, but internal hemorrhoids cannot be viewed. Okay, but to confirm, you can also go for digital examination. Now, digital examination, it doesn't mean that it is some sort of software or mobile smart device. You are not using any smart. Digital examination using the digits, using these fingers. This is the digit. Okay. So digital examination you are doing, what the doctors usually does is they put lubricants and they try to find out the piles, the swollen veins inside the anus. The thing about digital examination is it is very difficult actually. Like if you have done, then you will be able to relate this, that it is quite difficult to understand piles by doing digital examination, because basically you are trying to find veins against your mucus, against the mucus lining of the rectum or the anal canal, right? So that is very difficult to find veins against veins. So there, even if you do digital examination, and where do you need to see that is why that was important, that 3 o'clock, 7 o'clock, and 11 o'clock. That is why where you're gonna find out, you're gonna find out in these 3 positions. Okay, because you need to know geolocations in these times, right? So those are the geolocations for you to find piles. How? By using digital examination. So that is the first thing that you can do. But if that doesn't work out, then you can go for few endoscopies, like the anoscopy, sigmoidoscopy, and proctoscopy. So these are the things that you can suggest, and you can also simultaneously, I would suggest you to go for few routine examinations. Like I prefer going for CBC, that is the complete blood picture, and the coagulation profile. And also another thing is go and check patient's sugar level, because if the patient is diabetic, then chances are your medicine will take some time. His piles is going to take some time to cure, because we all know that diabetes is a type of disease that breeds other diseases. So if the patient is suffering from diabetes, then anything you give to the patient, that will take some time to act on his body, on the patient's body. So better you check for diabetes, better you check for coagulation profile, because if there is any disturbance in the coagulation profile, then that becomes harder for you to control the bleeding, because the blood naturally doesn't want to get controlled. That is when you go for coagulation profile. So these are the basic things that I suggest, and these are the basic things that I also usually recommend and write to the patients when I see a case of piles, and if I suspect, depending upon the age of the patient, if I suspect, then I ask the patient to go for these reports. Okay, so these were the investigations that are recommended. Next. Okay, the first thing before treatment of piles is prevention of piles. Now, why is this important? This is important because we need to remove the cause that has produced these piles, right? Because if the patient is suffering from constipation, then if I don't take care of the constipation, the patient will go on suffering from piles. If the patient is not like eating high fiber diets, what happens is when we eat high fiber diet, what that does, like vegetables, like fruits which has more fiber contents in it, so what that does is that increases the bulk of the stool, that increases these fibers, increase the quantity of the stool, that leads to softening the stool, that leads to less straining, and that ultimately relieves piles, that ultimately prevents piles. So these are the few things that I advise to the patient, and you need to advise to the patient first of all before starting the medicine, that you have to eat high fiber foods. If you are not, you have to drink plenty of fluids. If you are not, because drinking at least 7 to 8 liters of water, sorry, not 7 to 8 liters, 7 to 8 glasses, and that comes to about 4 liters, 3 to 4 liters of water is absolutely mandatory for a piles patient. Because the harder the stool gets of the patient, the difficult it is, the more difficult it will be to cure the piles of the patient. So eat high fiber food. At least 25 to 30 grams of fiber is the recommended dosage, or the recommended intake that I recommend all the patients to take. So for high fiber food, plenty of fluids, and absolutely don't strain, because the more the patient strains at his stool, the more that causes pressure in his blood vessels, the more it causes bleeding, the more it will worsen the case of piles. And don't hold back. As soon as you feel the urge to go to stool, go immediately. Because when you are holding back, what that does is that dries up the water in the stool, that leads to hardening the stool, thereby more worsening the piles. So don't hold back. And of course, the last thing is to exercise to prevent constipation and to reduce pressure on veins. So you can advise these things to the patient before starting the treatment. Next. So now a few homeopathic remedies that we can give to the patient who is suffering from piles. So as I was saying that the 5 symptoms, remember all those 5 symptoms, and most importantly the first 4 symptoms. So we will be prescribing medicines based on the patient's symptoms. If the patient says there is pain, there is lower back pain. Pain means the pain of piles. So if there is painful piles, if the piles are painful, along with that, plus there is lower back pain and there are no bleeding, then the medicine is Aesculus hypocastanum. The medicine is Aesculus, because we know that in Aesculus we have blind piles. What does that mean? In Allen's keynote, it is given blind piles means there are no bleeding, and we know that Aesculus is a wonderful remedy for lower back pain. So if there is hemorrhoidal pain plus lower back pain with no bleeding, the medicine is Aesculus hypocastanum. On all these medicines that I am saying, and all these combination of symptoms, these are the things that I look in the patient and I prescribe the medicine that leads to my success, that ultimately cures those 80% of the cases that I am talking about right now. So if there is pain plus lower back pain and there is no bleeding, the straight away medicine is Aesculus hypocastanum. See, because one thing I believe is, when a piles patient comes to you, he is already suffering from some form of symptom or not. Okay, a piles patient or a patient will never come to you and will ask you for a piles treatment so that he doesn't, or she doesn't suffer from piles in future. This is not going to happen. This might be a case when patient is coming to you for prevention of some other diseases. This might be a case which is happening with some other diseases. But with piles, you can be 100% sure that this is never going to happen. At least this has not happened to me, that a patient is coming to me and asking for a piles treatment so that he doesn't suffer from piles in future. That is not going to happen. So if a patient is coming to you with piles, he is suffering from some form of symptoms, and you will have to give relief to this patient within a week or so, because that patient is not going to stick to you for a month or 2 months or 3 months and with continuing with all these symptoms, and you expecting the medicine to act and like give them time and the patient will give you time. That is not going to happen, because at max the patient is going to stay with you for that symptom with max to max 15 days. So you will have to give some relief to the patient in those 15 days. Means within the first week you will have to provide with him with 50% relief. And these medicines that I am saying, this will provide you like more than 50% relief. So the first medicine that we learned for piles, pain, lower back pain, no bleeding, the medicine is Aesculus. Next is, if the hemorrhoid is painful, if there is pain, there is itching, there is bleeding, pain, itching, bleeding, which is ameliorated by cold, the medicine is aloes socotrina. When there is pain, along with pain, the patient is saying that there is itching, and along with itching, there is also bleeding. And all these pain is getting ameliorated by applying cold application. Then the medicine is aloes socotrina. Now, in few cases, what I have seen, patient doesn't know if his symptoms, if his pain, if the pain or if the symptom is getting relieved by cold or getting relieved by warmth. But I know I need to understand this. So I ask the patient to check this, to confirm whether your symptom, whether your pain, whether your itching is getting relieved. Apply cold ones, then after apply cold ones, then after a few days apply warm water and see which one you find better. So pain, itching, bleeding, ameliorated by cold application. The medicine is aloes socotrina. Next, third symptom or third medicine is, there is intense pain. There is intense pain. Intense pain means unbearable pain. Along with pain, there is itching, which is ameliorated by cold application. The medicine is Retania. Pain, intense pain means out of all proportion. The patient will say that bahut pain hai. Plus itching, which is ameliorated by cold application. The medicine is Retania. Fourth medicine, there is pain plus burning, which is ameliorated by warmth application. So if the patient is saying by cold application, means his symptoms are getting better by cold application. So I know, okay, I need to select between these two medicines. It might be aloes, it might be Retania. But if the patient is saying that his symptoms or her symptoms are getting better by warmth application, then the medicine is Arsenicum album, because we know that in general all the burning sensation of the arsenic has burning, and that gets relieved by applying something warm. So that is Arsenicum album. And to confirm Arsenicum album, we know that Arsenicum album arsenic patients suffers from prostration. So along with that, if the patient is too much prostrated, in general prostration, if the patient is too much prostrated, then we can almost say it with surety that we can prescribe Arsenicum album for this case. Next, moving on, another symptom or another medicine during pregnancy or after childbirth, means the piles developing during pregnancy or after childbirth. The medicine is Collinsonia. During pregnancy or after childbirth, the medicine is Collinsonia. And Collinsonia is also a good medicine if the patient is suffering, along with piles, the patient is suffering with any heart disease. If the patient has any heart disease and the patient is also suffering from piles, then we can also think for Collinsonia. Because in Collinsonia, we have this condition, the hemorrhoids are developing as a result of heart diseases. So if these two combinations we are able to find in a patient, then we can prescribe the patient with Collinsonia. Next, few patients will say that their piles are extremely sensitive. बहुत ज़्यादा sensitive. How we will ascertain this? How we will know this that the patient means that? Because the patient is unable to sit. Why? Because the piles is too sensitive. The patient doesn't if okay, I'll tell you the medicine later. So the patient will be not able to sit. The patient will be unable to sit because the piles is too sensitive. The patient will not be able or will not find wearing underwears comfortable because the piles is too sensitive. So when the piles is too sensitive, the medicine is, just a second. The medicine is muriatic acid. Piles too sensitive, the medicine is muriatic acid, and this muriatic acid is also prescribed. I also prescribe muriatic acid when piles develop in a children. If a children is suffering from piles, muriatic acid is also a very nice suggestion. We can also use this medicine if we find piles in a children. So sensitive, so piles extremely sensitive, medicine is muriatic acid. Next, there is pain plus there is bleeding. There is pain plus there is bleeding. Pain is also more, bleeding is also more. The medicine is aceticum nitricum or nitric acid. That is the medicine. Pain is also more and the bleeding is also more. The medicine is nitric acid. And I usually prescribe this medicine of this if I find this symptom that there is pain, there is bleeding, then my first choice of medicine is nitric acid, and I think that has relieved so many cases of piles for me. Nitric acid medicine that has relieved so many piles for me, pain plus bleeding. And if the patient is fearful, because I have found that a lot of piles patients are fearful. They fear that, just I was saying now, a patient will inquire a lot about his disease, about their diseases, like what is the degree of piles or how bad is their piles. So these are the signs, these are the things that we can say that the patient is fearful for his disease. And by having a talk with the patient, we can understand a patient is too much concerned about his disease. So if there is pain, if there is bleeding, and if there is fear of disease, if the patient is fearful, how bad is his piles or how bad is the piles, whether the piles is gonna get cured or not, this indicates that the patient is fearful. So in that case, we can prescribe nitric acid. These are the symptoms for nitric acid. Next is pain aggravated by sitting, and almost 50% of cases of piles and 50% of patients with cases of piles will say this. This is such a common symptom. Pain aggravated by sitting. The medicine is Thuja. Pain aggravated by sitting. The medicine is Thuja. Next is pain aggravated by soft stool, ameliorated by walking. Now this is one contradiction. How can pain be ameliorated by walking? If something is paining, you need to take rest. Then only the pain goes away. But here the pain of hemorrhoids is getting ameliorated by walking. The medicine is Ignatia. And the pain is getting aggravated by soft stool. What happens usually? What we have discussed so far, that the piles will get aggravated when there is hard stool. Means we are trying every bit to make the stool soft. But here the patient is coming and saying, okay, when the patient is passing soft stool, the pain is getting aggravated. When the patient is trying to walk, then the patient is feeling better. So that is completely contradictory symptom, and we know contradiction is the main thing of Ignatia. So pain, aggravation, soft stool, ameliorated by walking, medicine is Ignatia. Another symptom, pain which is ameliorated by sitting on hard surface. Pain aggravated by sitting on a hard surface. Medicine is Calica. Pain aggravated by sitting is Thuja. Pain ameliorated by sitting on hard surface is Calica. Aggravated by sitting, Thuja. Ameliorated by sitting, Calica. When there is piles which has developed as a result of chronic constipation. We just now did that chronic diarrhea, chronic constipation, these are the causes of piles. These ultimately leads to piles. So piles that has developed as a result of chronic constipation. The patient has been suffering from constipation since a very long time. And now the patient is saying that the patient is also suffering from piles. And upon inquiry, taking history, we find out okay, the patient has been suffering from constipation. The medicine is causticum. Means piles plus constipation. The medicine is causticum. And in causticum, if we see, causticum is also, there is another important symptom for causticum, that stool piles impede stool, or the piles impede stool, means the passage of the stool is blocked by piles. That is also a very good symptom of the patient will come and say that when I am trying to pass a stool, I cannot pass a stool. Why? Because of the piles. That is one very important symptom. Another very important symptom of causticum. If we get that symptom, that stool gets impeded by piles, fine. If we don't get that symptom, even if I get piles plus constipation, we can straight away prescribe causticum. Next is painful piles, where the piles are painful and there is fear in the patient to pass a stool. The fear is not of the disease. The patient is not fearful whether the piles is going to get cured or not, or whether that will turn out to be something huge or something major or not. So the piles is painful and the patient is fearful to pass the stool. The medicine is sulfur. The medicine is sulfur. Yeah, I might I know the 40 minutes are over. I might require just 2-3 minutes more. I'm already I'm almost done. This, I think, this is the second last slide. So pie is painful and there is fear to pass a stool. The medicine is sulfur. In sulfur we have child cries while passing stool. That is sulfur. Next few emergency medicines I want all of you to know regarding piles, along with all the symptoms and all the medicines that we have done so far. Just remember few emergency medicines, because when a patient is coming to you, the patient might require few emergency medicines. The pain might aggravate like anything. The bleeding might go on for anything, might become aggravated. So you need to prescribe few medicines to the patient, because to control in case of emergencies. So the first emergency medicine that I think to prescribe, and I usually prescribe, is Hamamelis. That I prescribe to control the bleeding of piles. We know that Hamamelis is a very good medicine for piles, for venous congestion, for any kind of bleeding, for any sort of bleeding. So that is one, and all these I prescribe in mother tincture. Okay, and that too in SOS form. If there is bleeding, you take this. If there is no bleeding, you don't have to take. That is the emergency medicine. So first, hemorrhage, if to control bleeding, the first medicine of choice is Hamamelis. If the bleeding is not getting controlled by Hamamelis, then what we will do? We will prescribe Blumia. If the bleeding is not getting controlled by Hamamelis, we prescribe Blumia. If the bleeding is not getting controlled both by Hamamelis and Blumia, then comes the savior. The medicine is Ficus religiosa, and that medicine is the hemorrhage arrestor. That medicine, this Ficus religiosa, will stop any sort of bleeding. Hematemesis, hemoptysis, means menorrhagia, means any sort of bleeding of piles. This medicine will stop any sort of bleeding. This medicine is a hemorrhage arrestor. So Hamamelis fails, Blumia fails, prescribe Ficus religiosa. Rhytania is not prescribed. I don't prescribe this medicine in mother tincture. Rhytania I also prescribe a lot of times when there is extreme painful hemorrhoid. When the pain is so extreme that the patient cannot bear, I prescribe the medicine Rhytania just for emergency. That in case if the piles aggravates, if you have a lot of if you get unbearable pain during piles, you just take this Rhytania for few days. That is the medicine. And one last emergency medicine that we can note down is Peunia or Pinia, however it is pronounced. So there is pain, and along with pain there is painful ulceration. and along in the ulceration there is oozing of the ulceration that causes pain. That may be during stool, that might be after stool, but pain plus painful ulceration, that means oozing ulcer. So pain plus oozing ulcer, that is pinia, that might be before stool, that might be after stool. Okay, so these were the emergency homeopathic medicines for piles. And thank you everyone, and these are my few social media handles, because you can note down, and I usually upload a lot of videos, clinic related videos on files, on a lot of things, whatever I like find important, and whatever I mostly I receive patients from, and patients are suffering and patients are coming to me, like hair fall, piles, then renal stone, another a very useful place where homeopathy acts wonderfully in case of renal stones. So I usually upload all those videos. Yeah. So thank you everyone. This was my discussion for today.
Dr. Sukhendu, are you audible? Dr. Sukhendu, can you hear us? Sukhendu, directly mobile কথাটা বল. Remove the headphone. You can speak directly. I think you will be audible.
আচ্ছা ঠিক আছে
Now
শোনা
you are
যাচ্ছে, আমি
audible.
শুনতে
Go
পাচ্ছি।
ahead. Yeah. Please do your moderation part.
So Dr. Taha Khan nicely described about the piles, internal hemorrhoids as well as, and he vividly described the piles, degree of piles, its management, and the symptoms of different cases of piles. Now, as we know, the piles, mathematically, is a mostly psychosoric origins. So some, not only psychosoric, there is a different others of miasm according to his soric. When there is soric, there is itching, etc., etc. So he giving described the symptoms. As a novice practitioner, that is very good for piles. Then we go to the case totality. If there is a miasmatic background as well as whatever miasm, and he already covers all the medicines. Among them, we give the most similar medicines as per case totality, that will there is a good result in homeopathy in cases of piles. Okay, viewers, we are enough knowledge gained from the some piles about Dr. Taha Khan. Next, we waiting for Dr. Ghulam, and I am thankful to Dr. Kalyani sir and Dr. Bidyut Mukherjee also. Thank you.
We'll request Orko to bring upon Dr. Ghulam Nabi Wani on screen. And before we introduce or accept Dr. Ghulam is from our topmost northern part of India, Kashmir. And the time we were having our offline CME, that is physical CMEs at NIH, Ghulam was doing his PG, and he was one of the main architect to run the CME, offline CME at NIH very successfully. Over to you, Dr. Ghulam.
Thank you, Bidyut. Am I audible and visible? Good evening, everyone. Hello.
You are audible and visible. Perfect. Go ahead.
Yes. One minute. It will take 1 minute. Hello? Hello?
Ghulam, you are audible.
Yes, we are uploading our
Ghulam,
presentation.
we can't see you.
Yes, I am uploading my presentation.
Okay,
There
okay.
was some technical fault. It will take a few
Okay,
minutes,
okay. You
few
just go ahead
seconds.
in between. Okay, okay. Go ahead. For our respected viewers who are watching live now and will be watching in the later stage, the recorded version, for all the viewers relating to Dr. Taha, uh, some introduction need to be done. He is a first-time entrepreneur and doing something new for the PG students. He is having his own online classes, probably Prayash classes or something, but he is doing excellent. And hats off to this new generation of homeopaths because there are a lot of avenues, not only the practicing of our great Master Hahnemann's teachings, but also propagating his teachings and also getting updated with the modern technology. So this is the main purpose of our CME. We are trying to unite each and every part of it. And by the time Dr. Ghulam is uploading his session, it's a brief appeal for all the alumni across the globe. Since 1987, BHMS had started, but before that, from 1975, the birth of NIH in Kolkata. It started at Howrah, went to Amer Street. From there on, NIH now at present at Salt Lake NIH campus. We are having almost 2,000 plus alumni across the globe. Now, it's a humble request to all the alumni. Please convey the message that each and every alumni must get in touch with each other so that we can use this platform for the betterment of homeopathy. Now, Ghulam is back. Over to you, Dr. Ghulam.
Thank you very much. Thank you, everyone. Thank you, my seniors. Thanks, my teachers, everyone. My today's topic is related to skin. First of all, let us go through the briefly about this skin. This is the largest organ of our body, as we all know. It has got three layers. One is epidermis, the second is dermis, and third one is, a bottom layer, that is fatty tissues. Let us go through the etymology word of this vitiligo. Uh, this is basically a Latin word, vitilus. That means it's a cough, and first used by the Roman physician Celsius of the 1st century AD. The characteristics patches of the disease resemble the white patches of the cough in India. That's why it has been given the name of vitiligo. Uh, what is vitiligo? As we all know, this is nothing but it is an acquired idiopathic skin disorder characterized by progressive loss of inherited skin color, leading to white patches and even total depigmentation due to the destruction of the melanocytes that is thought to be mediated by immunological mechanisms. This is the definition of the vitiligo. I have tried my level best to assemble this definition from many books. This is the gist of all the books. I don't know how much I could able to put this on the screen, the definition of the vitiligo, but I think this is the most accurate definition of the vitiligo. Uh, Before going to the etiology and before going to the course and the clinical features of the this vitiligo, let us know briefly about the melanin. It's a pigment which is produced by the melanocytes. These melanocytes are present in the basal layer of the epidermis, as I have already told you that, yeah, as we all know, this our skin has got 3 layers. It is there in the basal layer of the epidermis. These melanocytes lies. There are two forms of melanin which exists actually. One is eumelanin, that is black or brown pigment. Another one is pheomelanin, that is red or yellowish pigment. Then about the etiology, as we know, the etiology is unknown till now. Medical science has done a lot. I mean, we have we have done many things in this health sector, but there are still many diseases. The etiology, the causes of the disease are unknown, and vitiligo is among them, where the cause is not still known. So but there are certain hypotheses, there are certain theories which proves that how this vitiligo happens, how what are the changes which happens during this vitiligo. So let us go to this one by one. The first is autoimmune hypothesis. That means how it proves that the homeopathy this vitiligo happens. That means this autoimmune hypothesis says us that there is frequently associated with autoimmune disorders like alopecia areata and hypothyroidism. As we know, this alopecia areata and hypothyroidism, this is autoimmune disease. So frequently we see this vitiligo in such patients. So once we are treating those patients, we treat simultaneously these patients. Vitiligo is getting treated simultaneously once we treat hypothyroidism and alopecia areata. So the cause of alopecia areata and hypothyroidism is autoimmune hypothesis. So this goes this hypothyroidism and alopecia areata is often associated with vitiligo. If we will see in this autoimmune this vitiligo patients, there is presence of antibodies to melanocytes. This proves that this vitiligo is autoimmune disorder. That means once there is presence of antibodies to the melanocytes, so this proves that vitiligo is one of the autoimmune disorder. Simultaneously, you will find in many patients, in many cases, there is presence of T lymphocytes in early lesions. That means whenever there is this vitiligo, their patch develops in our body. If we will go for the examination, you will find presence of T lymphocytes. That means these T lymphocytes we see frequently in autoimmune disorders. So here in vitiligo, we see in early lesions also these T lymphocytes. Then the second one is genetic. That means it runs from families to families. As we all know, it's a heterogeneous, complex, polygenic disease with environmental influences. Around 20 to 30% patients have positive family history. If let me tell you, I have treated a number of cases there at NIH and here in Kashmir. I have seen there is a genetic. I mean, there is hereditary. It runs in families from either from mother side, maternal side, or paternal side. So that means this has got a genetic this effect. Then this third one is neurogenic hypothesis. So how it proves that this neurons have got some role in this the destruction of the melanocytes. We have found certain toxins released at nerve endings destroy melanocytes. So at nerve endings, you will see wherever there are the nerve endings. I will later on, I will tell you which vitiligo has got this neurogenic hypothesis, where it works. I will tell you later on, but let me tell you this: there are certain toxins released at the nerve endings which destroys the melanocytes, and there is the development of the hypopigmentation patch in the body. The second one is, most affected parts are those supplied by the mandibular branch of the trigeminal nerve. If you will see this mandibular branch of the trigeminal nerve, you might have gone through, you might have seen patients having patches around this area where there is the supply of the mandibular nerve. So there, that means the terminal part of this mandibular nerve, it ends here. So whenever these toxins are released here, so this leads to the hypopigmented patch, and that proves that there is a neurogenic hypothesis also, which is responsible for the destruction of the melanocytes. Then comes the this biochemical hypothesis, which we see there is the defective antioxidant defense, which may increase susceptibility of the melanocytes to immunologically mediated cytotoxicity. Then let us go through the epidemiology. There is incidence, you will see that occurring in about 0.5% to 1% of the population worldwide. As high as 8.8% prevalence have been reported in India, affects all races equally. That means in India, if we will see, it has as high as 8.8% prevalence, which has been reported from India. That means from our country. It affects all races. That means there is no age group, no one is immune to this. It affects all equally. Gender, there is no gender predilection. Age, it affects all ages, as I already told you. The peak incidence, but the peak incidence is between 10 to 30 years. So the peak incidence of these this vitiligo cases we have seen between 10 to 30 years of the age. Genetics, positive family history varies from one part of the world to another. If we'll talk of India, our country, we have a positive family history ranges from 6.25% to 18%. Here in India, the positive family history ranges from 6.25% to 18%. Some studies reveal it as high as 40%. So this is very significant over here. Then let us go through the morphology, the clinical features of this vitiligo. Their main clinical feature is hypopigmentation of the body, hypopigmentation of the skin. So how it is presented? So there are the presentation is in a different manner. The first the case which we see in vitiligo, there is having depigmented macules which are chalky or milky white in color. Sometimes the pigment loss is partial and occasionally can present in 3 shades. Trichrome, seen in same lesion, depigmented center. This is depigmented center. This is depigmented center. They're surrounded by hypopigmented rims. This surrounded by hypopigmented rims, as has normal pigment skin around it. This is normal pigment skin around it. So this is sometimes it is presented in the form of trichrome, having depigmented center, surrounded by hypopigmented rim, surrounded by normal pigmented around it. Often perifollicular pigment is retained, giving the lesion a speckled appearance. See here, you will see these are the hair follicles lies over here. So there is at these junctures you will find there is loss of this skin color. You will see the skin color is intact over around the hair follicles. But if you will see this which is away from these hair follicles, there is depigmented spots. There is depigment spots. So this gives a speckled appearance. Then we have macules have a scapuloid outline and from geographical pattern on fusion with neighboring lesions. See, this is this forms. This is just like a geographical. See these hands. This is giving the geographical appearance. See this is hypopigmented area. So this which is surrounded by the normal skin color, and it gives a geographical appearance, and that is called as scalloped outline. Sometimes there is linear lesions are seen which are due to Kubner's phenomena. That is isomorphic response, appearance of lesions along a site of injury. You will see this. See, this patient might have history of injury. This is, see, there is isomorphic response. That means this hypopigmentation has developed along the injury site, which is called as Kubner's phenomena. Then sometimes you will see hairs usually remain pigmented. See this picture. You will see hypopigmented patch. There is hypopigmentation, but see the color of the hairs. Color of the hairs is still intact. So there is black hairs, and but there is the scalp. The color of the scalp has got changed from the normal skin color to hypopigmented skin color. But the this color of the hairs are intact. So this is sometimes you will this vitiligo patient may present in this form also. But in some cases of segmental vitiligo or other older lesions, it may turn gray. You will see this picture. See this eyebrows. This patient has developed this patient has developed hypopigmentation, hypopigmented patch. Along this patch, this patient, this eyelashes plus eyebrows both have the changes of the both these eyebrows and eyelashes has got changed from the black to white gray rather. So sometimes this is seen in segmental type of vitiligo or lesions which are older in nature. So in those cases you may see simultaneously the color of the hair follicles, color of the hairs are also get changed from normal color to graying or the white color. So this is usually seen in the segmental vitiligo or older lesions. You see here this is also here there is a graying of the hairs plus there is hypopigmented patch over the right eye. Then comes there are different patterns of vitiligo. One is segmental, another is non-segmental. In non-segmental, we will see localized. Under localized, we will see focal. We will see mucosal. And this under this non-segmental, the another one is this one is general localized, which is locally placed, and another is generalized, which I mean which affects our body as a whole. I mean, in general manner, not only in one spot, not only in two spots, but in at different areas. So that is called as generalized. In generalized, you will see vitiligo vulgaris, you will see acrofacial vitiligo, and you will see vitiligo universalis. Let us discuss all these one by one. First of all, let us go to the segmental vitiligo. There is one segment of the body is usually involved, manifests itself as unilateral, single, multiple, oblong, depigmented macules. You will see one segment is, I mean, involved here. You see. Usually, I told you previously, if you will see this segmental vitiligo, here in segmental vitiligo, you will see this trigeminal nerve. The branch of this mandibular nerve is the branch of the trigeminal nerve. So this trigeminal nerve is affected in this by vitiligo. The mechanism here is that there is some nerve toxins which are released at the end of the nerve. So that means this is mandibular division. That means when at the end of the nerve, when these sort of these neurotoxins are released, so that leads to the destruction of the melanocytes, and that destruction of the melanocyte finally leads to the hypopigmentation of the area. But it is, they see one segment is involved, this whole segment is involved. So this is called as segmental vitiligo. That means mandibular, the area which is I mean supplied by the mandibular branch of the trigeminal nerve here is involved. So one segment is involved, that is called as segmental vitiligo. Here the onset usually is in childhood. It is usually seen in the childhood, usually not associated with autoimmune diseases. Leukotrichia seen usually in depigmented areas as well as in non-vitiliginous areas, may affect any segment, but most commonly seen along the distribution of the trigeminal nerve, especially mandibular division. Lesions increases in size and shape initially, but later on has stable course. Then that means the lesions remain static. Initially, it may increase in size and shape, but later on, once it it involves the whole segment, then it remains static. That means it won't cross that border. That see, that means it won't cross. It won't go to this side. It won't go to this side, because mandibular, this branch of trigeminal nerve supplies this area. So once this whole this trigeminal, the area which is supplied by the mandibular branch, once it has affected this whole area, so it won't affect, it won't cross the border, I should say. It won't cross the border. It won't go to that area which is being supplied by the some other nerve. So this is segmental vitiligo. And we will see this does not respond to the treatment so easily. It is very difficult to treat. Then comes focal vitiligo. Focal means neither it is segmental nor it is, generalized. It is focal. The focus is at one point. See, this is usually this patient. It is on the front of the abdomen. It is above the this umbilicus, on the center. Neither it is there, lies on the right side, nor it lies on the left segment. So it is on the center. So this sort of this type of vitiligo is called as focal vitiligo. These are acquired small hypopigmented or depigmented lesions which do not fit a typical segmental distribution. As I already told you, then they do not evolve into a segmental vitiligo or vitiligo vulgaris over a period of time. Already I told you, it is neither on the left segment nor on the right segment. It is on the front of the abdomen. It will remain there, and neither it will go to this side nor it will go to that side. So this is focal. This is limited to one area only. Then comes mucosal vitiligo. The nomenclature is, if we'll go by the name, that means it should, affect the mucous membrane. So wherever you will see the mucous membrane, it will affect there. See, this is a typical picture of the mucosal vitiligo. It has affected the mucous membrane of the lips. Said there is depigmentation of the oral mucous membranes, usually lips and in genitals of the both males and females, may present as an isolated spot or a part of generalized vitiligo. Then there comes vitiligo vulgaris, which is the commonest. Among all, occurs after second decade. May progress slowly or rapidly. The family history is frequently seen. It runs, this, if you will see vitiligo vulgaris, it runs in families. There is, it may progress slowly or it may progress rapidly, and it has been seen usually from second decade onwards. So this is vitiligo vulgaris, which is commonest among all. Then there comes acrofacial type of vitiligo. This goes by the nomenclature itself. Acrum means these fingers and this this outer part of our hands or this feet. This is acrum. This is called as acrum. And facial means this face, and usually it affects this area. So this is the typical picture. The maximum pictures which I show you here, which rather I have shown you here and I will showing here, I have captured from NIH OPD, and these are the real pictures which I have taken. Captured from these patients, those patients who came to NIH for this regular visits. So this is one of the picture. This is the depigmented, if we'll go by the definition of the acrofacial vitiligo, this is depigmented area seen around eyes and the lips of the face, periorofacially, periangual areas, palms and soles, dorsi of the hands and the feet. Then comes lip and tip vitiligo. Again, lip and tip. Lip means, as you see from this picture, it has affected the lip of the patient, and it has affected tip of the patient. So tip of the patient is, I mean, it is on the nipple of the breast of the patient, or it may affect the tip of the penis, or it may affect the vulva and nip of the patient. So this type of vitiligo is called as lip and tip vitiligo. So this is also a real picture which I have taken, captured from the patient. One of my, was a junior. She has taken these pictures from the patient. So this is one of the real picture, again, which I am showing you, which I have captured, which I have taken from the patient in NIHOPD. This is very difficult to treat due to the non-availability of the hair follicles. Again, when wherever you won't see this hair follicles, the area which is affected, where the hair follicles are absent or less in number, that area is very difficult to treat. So these melanocytes you won't find, you will find this melanocytes there, but not in abundant quantity. So very difficult to cure such type of patients. Then there is vitiligo universalis. This is again a real picture which I have captured from a patient in NIHOPD. This is the major portion of the body is involved. Only few portions of the body is spared. You will see this hole is there are only few, I mean, these spots left of the normal color of the skin. Rest is, I mean, has turned into the hypopigmented these areas. So often associated with multiple endocrinopathies. So patients having this type of vitiligo, you should always search for different or multiple endocrine disorders. You should pay. We must evaluate those patients for endocrinopathies. Then there are these sites of predilection. See, lesions can occur anywhere in the body. There is, I mean, no area is immune. It can affect anywhere in the body. But lesions can occur in any part of the body, but areas subjected to repeated friction and trauma are more affected, i.e., dorsal aspect of the hands and feet, elbows and knees, etc. There is segmental vitiligo is most frequently seen along the distribution of the mandibular division of the trigeminal nerve, and mucosal vitiligo is seen on lips and the genitals. This is the predilection of the sites of the vitiligo. Although no area is immune, although no area is, I mean, I can say कि मतलब this cannot affect this and that area, but we have seen in majority of the patients, we have seen those areas which I have already shown you. See, this is the dorsum, this dorsum of the hand, which is subjected to the repeated friction and the trauma. Then there are feet, elbows and knees. Segmental vitiligo, which I already discussed. This is mucosal vitiligo, which I have already discussed in the previous slides. Then course, it runs differently. See, vitiligo patch usually progresses slowly. You will see patients developing hypopigmented spots initially. I mean, the head of the needle, later on it turns to the P of this P size. Then later it turns to it involves the skin slowly and gradually. But in few cases, in rare cases, you will see the vitiligo progresses very rapidly. Usually we see vitiligo progresses very slowly. Sometimes the progress is fast, especially when the disease is in active phase. The segmental vitiligo progresses initially but stabilize around 6 to 12 months, which I have already told you. Once it affects the whole area, the area which is being supplied by a particular division of the nerve, once it affects the whole area, then it won't cross that border, because that the area uh, which is not being covered by this that particular division, so that division won't be affected. So at I have already, I mean, discussed in the previous slide, in which is the classical case of mandibular nerve, that is the trigeminal branch, how it affects that area. Then there is a spontaneous repigmentation. If if we will see the course of this vitiligo patients, there are many cases which is which gains, I mean, which regains spontaneous repigmentation. That means vitiligo usually usually progresses slowly, but in few cases you will see fast progress. In few cases you will see progresses initially, I mean, fast, very fast, then stabilize after few weeks to few months. Then there is in such patients, in many patients, there is spontaneous repigmentation around 10 to 20%, especially in sun exposed parts. So parts exposed to sun are easily getting cured, or there is easily repigmentation of the this hypopigment spots. So uh, then if you will see this acrofacial vitiligo, this is a resistant one and very difficult to treat. This once you will see or you come across a patient of this acrofacial vitiligo, this is a very resistant one and very difficult to treat. The only reason is that this why this acrofacial vitiligo is very resistant and very difficult to treat, because at these areas there is in this either if you will see, you know, on the face or on the lip, you will see there is no hair follicles are there, so less quantity of melanocytes are not abundantly present over there. So it is very difficult. And if you will see in the this these areas, these acrum, you will see there are less hair follicles. So these, when there are less hair follicles, chances of melanocytes are, I should say, melanocytes are present less in number there. So repigmentation is not so easy. So it is very, that's why it is said these cases, acrofacial vitiligo cases, are very resistant one and very difficult to treat. Then if we will go through the prognosis of the disease, uh, although it's not written anywhere there is poor and relatively good prognosis, but I have assembled in this in this fashion, I which I have seen in these last few years. Long standing cases have got very poor prognosis, means patients who is suffering from vitiligo for last 10-15 years, chances of repigmentation is very rare. Then acrofacial type of vitiligo, which I have already discussed, lesions on resistant areas like bony prominences, non-fleshy areas, non-hairy areas, and mucosa. I have already discussed. There is presence of leukotrichia. That means if there is simultaneously this vitiligo has affected the hairy area, and those hairs have turned gray, or uh, uh, this uh, these hairs have turned white, so the chances of cure is very rare. Chances of repigmentation is very rare. That indicates there is complete destruction of the melanocyte, so there it won't be this repigmentation in future. uh, Persons who are suffering from autoimmune disorders are also those patients have very poor prognosis. And patients having a segmental type of vitiligo, which I have already discussed, they have got a very poor prognosis. Now, relatively good. Which patients have relatively good prognosis? These lesions which are recent in origin, these lesions which has affected children. I mean, hypopigmented, this vitiligo, which is seen in childhood. Pigmentation of hairs intact. That means areas, vitiligo patches, where there are hairs and the color of the hair is intact. They have got a good prognosis. And over hairy areas. That means if this vitiligo if vitiligo affects hairy areas, chances of repigmentation is good. The reason is that because around these hair follicles, melanocytes are present in abundance. I mean, they are present. There is presence of this melanocytes are there. So these uh, patients having these, which fulfills these criteria, having relatively good prognosis. Then associations. It is associated with many disorders, skin disorders like alopecia areata, halo nevus, atopic dermatitis, malignant melanoma, and morphea. Then there are certain endocrine disorders like diabetes mellitus, like Addison's disease, like hypoparathyroidism, like hypo and hyperthyroidism, like pernicious anemia, etc., etc. So these are the there are number of diseases which has got association with this vitiligo. There was a study on this association between vitiligo and the thyroid dysfunction. It was conducted at the Neerath Sarkar Medical College, Kolkata, by Malika Biswas et al. With sample size of 100. Their observation was that 28% of vitiligo patients had hypothyroidism as compared to 6 controls. Out of 28 hypothyroidic cases, anti-thyroid peroxidase antibodies were present in 19 cases as compared to 2 controls. So if we will see this hypothyroidism and vitiligo, there is a direct, I mean, association. That means this study has found that this vitiligo patients and the hypothyroidism patients have got some, I mean, this association between them. So the conclusion was that vitiligo usually precedes the onset of the thyroid dysfunction. Periodic follow-up of vitiligo patients for detecting thyroid disease is further emphasized, especially in patients with increased level of anti-TPO. And then there is points which favoring a diagnosis. Uh, it is that means onset after birth. If this hypopigmented patches are present before birth, that means rather at the time of birth, that case is that condition is called as albinism or piebaldism. Then depigmented macules, milky white with scallopoid borders, presence of leukotrichia, presence of Kubner phenomena, predilection for sites of trauma. So if these conditions, if we'll find such type of conditions, then we can say this is vitiligo. But if it is present before birth or at the time of birth, that if you will find a child having hypopigmented spots at the time of birth, so that is not this vitiligo, that is something else. Either it is albinism or there are many syndromes which we will discuss later on. Then differential diagnosis. If we will go for this hypopigmentation, if it affects generalized, then there are two conditions. One is oculocutaneous albinism, and second one is HP syndrome. That means Hermansky Podalic syndrome. If it affects localized, that's locally, then there are different conditions that is called as piebaldism, pityriasis versicolor, pityriasis alba, leprosy, and nevus. So let us discuss one by one. This is oculocutaneous albinism. It is very the color of the patient. This child is he is very pale or pinkish complexion with flaxen white or slightly yellowish hair and very light blue or even pink eyes. You will find nystagmus, either horizontal or rotatory. You will find extremely that patient, those patients are extremely sensitive to the harmful effects of the solar irradiation. often develop skin cancers. Albinos has normal number of melanocytes. It's not here. This is interesting. This albinism, the patients who are suffering from albinism, they have normal number of melanocytes, but they lack tyrosines, tyrosinase, and unable to synthesize melanin. So tyrosine activity is not there. So though tyrosinase is not present in them. So because of that, these melanocytes are unable to synthesize melanin. So in albinism patients, melanocytes are there, but those melanocytes are not able to synthesize melanin. Then there is Hermansky-Podalic syndrome. It's a very rare, extremely rare syndrome. It's also an autosomal recessive disorder. This is in this Podalic syndrome, Hermansky-Podalic syndrome. You will find three features in them. One is albinism, all features of albinism. Number two is they are having bleeding problems due to the platelet abnormality. That means normal platelets are not there, so there is bleeding problems in such patients. And third is storage of abnormal fat. So there is cellular storage inside the body which leads to the obesity, rather we should say abnormal fat deposition over different areas. Then comes localized hypopigmentation. If we will, those HP syndrome and albinism was the generalized hypopigmentation. Now, if we will discuss localized hypopigmentation. The first one we will discuss is piebaldism. This is rare autosomal dominant disorder of the melanocyte development. Common characteristics include congenital white forelock, scattered normal pigment and hypopigmented macules, triangular shaped depigmented patch on the forehead. See, this is, you will see in piebaldism. It differs from albinism in that the effective cells have cells maintain the ability to produce pigment but have the specific function turned off. Then comes pityriasis versicolor. As we all know, I won't take much time here because we have already exhaust this session over here. I will discuss now briefly these conditions. Pityriasis versicolor is yeast infection. It's non-dermatophyte infection. Usually fungus, we should say. This is caused by the Malassezia globosa, or in few cases it is caused by the Malassezia furfur. These yeasts are normally found on the human skin and becomes troublesome only under certain circumstances, such as warm and humid environment. However, exact mechanism is not known. Then there is localized hypopigmentation. This pityriasis alba. You will see this is pityriasis alba. See, this is pityriasis alba. It affects children and young adults. Exact cause is unknown. Condition may be associated with eczema. Then there is leprosy. You will see this is hypopigmented patch, but this patch is devoid of, sensation. This is without sensation. It will prick this this area by your needle, so this patient won't respond. So if you will find such type of patch without sensation and with features of leprosy, then this patient is diagnosed as the case of leprosy. Then comes nevus anemicus, congenital vesicular anomaly. You see this area. This is not proper hypopigmentation. I should say there is skin color and between the hypopigmentation. This is the color. It is present clinically as the hypopigmented patch. Pallor is due to the localized hypersensitivity to catecholamines with resultant vasoconstriction. This is uncommon disorder and first described by the Warner in 1906. Then comes investigations. As such, no investigation is required. It is diagnosed clinically. Investigations may be required when vitiligo is secondary to some disorders like thyroid disorders, some autoimmune disorders, as I have already told you. This has got this disorder. This vitiligo has got this association with many autoimmune disorders. So if it is this vitiligo patients are suffering from some autoimmune disorders, so those patients have to be investigated for those disorders, not for vitiligo. And then comes the treatment. The treatment of vitiligo patient depends on age of the patient, severity of the disease, pattern of the disease, and effect on patient's quality of life. See, the general measures, as we all know, vitiligo it's basically a cosmetic problem. It's not a problem. By this till now, I don't think so. Anybody has died because of vitiligo or because of the complications of the vitiligo. But this is a cosmetic problem. So due to this, whenever patient develops the vitiligo patch, this patient develops some psychological symptoms. That means they are suffering from anxiety, depression. So there is a patient is having mood off. They may lost their interest with their day to day activities. So vitiligo patients affects differently. So it causes, depression, it causes anxiety, and it causes other psychological features. Anxiety grows as patients discover there is no certainty of a cure. Counseling can be helpful in coming to terms with these issues, and studies using cognitive behavioral therapy have shown promising outcomes, but more research is needed. Then general measures. There is phototherapy currently considered the global standard treatment when vitiligo covers 20% or more of the body. Slow process, heals from the outer edges of the each patch inward, may be continued twice a week for a year or more. Generally well tolerated in both adults and children. This is, that means, phototherapy. How this phototherapy is given. Then comes, other than homeopathic, this modern system has got many things to offer. So in localized lesions, what they do, they are using topical steroids in newly lesions, and topical POVA, Sorelin, and ultraviolet A therapy in old lesions. Extensive lesions, POVA combined with oral steroids if rapidly progressing. And there is surgical therapy in such patients who are resistant to disease. So in those cases, these melanocytes are transferred for stable and resistant disease. Then comes the homeopathic management. As we all know, I think maximum majority of us who are watching and who are hearing me are from this homeopathic side. So I don't need to, give you the concept of health and disease in homeopathy. So we all know there is concept of uh, totality of the symptoms, and the concept of this i mean uh, concept of individualization in homeopathy. So I don't need to go uh, the miasmatic overview of the vitiligo. I could not find any reference or paper of any kind of literature related to the vitiligo or lycoderma in our source books. It seems to be a multi-miasmatic disease condition as per the cause, manifestation, severity, and the parts affected. Skin affected over hairy areas have better prognosis than skin affected over non-hairy areas. Patients having hereditary tendency or suffering from some autoimmune disorders has poor prognosis. So this miasmatic overview, I did not find any paper. As I had gone through the many source books, I did not find any paper or any literature related to the vitiligo. But its cause, severity, course, by these all these things, I think I could come to the conclusion this is a multimiasmatic disease. Then comes homeopathic therapeutics. No, I mean, there is no specific. First of all, let me say, being an NIHN, we do not believe in specifics. So there is hardly I find one literature where I find this arsenic, sulfide of arsenic, which is R sulfur 11. is used to lessen the patch. Various stains were also advocated to temporarily conceal the existing condition. The homeopathic literature subsequently suggests a number of medicines for the conditions based on symptom similarity. So there is then comes the repertorial approach. This is very important. If if you want to treat the case of this vitiligo homeopathically, you have to consult repertory. Without consulting repertory, don't ever try to treat patient with homeopathic medicine, homeopathically rather, because as George Vitholkas has rightly said, the repertory has always been an indispensable tool in my practice. The absence of books on the desk may indicate experience and great knowledge in many other professions. For a homeopath, it only proves ignorance. So you should not never ignore this repertory. Once you have taken a case of this vitiligo, repertorize it, and you will find. I will tell you later on why repertory is important. Once I will, discuss one case, I will tell you why repertory is more important when you are taking this treating vitiligo patients. This is, my tool was this Kent's repertory. That means I, whenever I used to take a case, I used to consult Kent's repertory. In Kent's repertory, there is a chapter skin. In skin, there is a rubric that is called discoloration. Uh, Under discoloration, you will find sub rubric as white. In white, you will find many symptoms, many, I'm sorry, I mean to say many drugs. Some are second grade and some are third grade drugs. In second grade drugs are apis, arsenic, and kalikab, and third grade are calcarea, carboveg, fluoric acid, lacaninum, and Sambucus nigra. And under skin chapter, under discoloration rubric, under white sub rubric, under uh, sub rubric, you will find spots. That means white spots. There you will find many this many medicines. These are the medicines. And sub rubric, that means when these white spots becoming bluish, the calcarea cob is the medicine. When these white spots with dark borders, the calcarea cob is the medicine. This is, if you will consult this Cantus repertory, if you have to treat homeopathically, this is the chapter you will find under the skin chapter. Their rubric is discoloration, sub rubric is white, and then accordingly you can take your case accordingly. Rubrics related to the vitiligo mentioned in Boger Boning Hassan, characteristics and repertory. Their chapter is skin and exterior body. There you will find rubric spots, then white. These are the medicines. And you will also find many rubrics in upper extremities, white turning creosote. In mouth chapter, you will find white turning mercurius. In face chapter, you will see lips white turning, and the medicine is Valerina. This is in BBCR. Now, if you will go through the research, there are around 11 articles related to the homeopathy on vitiligo were identified. Four were clinical observational studies, three were case reports, one is double-blind, randomized, placebo-controlled homeopathic pathogenetic trial, one is a pilot data collection study within a program of quality assurance, improvement, and the development across all 5 homeopathic hospitals in UK, National Health Services, and one is a telephonic survey done at homeopathic clinic, Luca Homeopathic Reference Center region of Tuscany, Italy. So there are many research, papers. This is one. This was study number one, Chakrabarti et al. This was a this study was done at multiple centers. So that's why it's called as multicentric study. There were 432 samples at different CCR study centers across India. intervention was constitutional homeopathic medicine was given, prescribed on the basis of totality of the symptom, and the results were the marked improvement was seen in 4 patients, 2.94%, moderate improvement 15 patients, 11.03%, mild improvement 77, 56.62%, and non-significant improvement 30 in 25%. And there are these also these studies. I think the time does not permit us to go through all these studies. This is another study. This was the prospective open label clinical pilot study. Here 30 patients were enrolled, and the outcome assessment was measured by WASI VETF. WASI means Vitiligo Area Scoring Index. VETF means Vitiligo European Task Force, and Life Quality Index of the patient's result was significant in all three scales was noted. The study number 3 was this was the observational study of 102 patients. Study number 4 was observational clinical study of 282 patients. The intervention was again constitutional homeopathic medicine. Study number 5 was Jaha and debate. The study was case study. Intervention was constitutional homeopathic medicine. Outcome assessment done on the basis of the photographs preserved before and after treatment. This is outcome assessment. How we assess the patient and how we see what was the outcome of a result. This is a WASI score. Although this is not. I cannot explain this whole scale in few minutes. Let me tell you the introduction of this scale. Here, this was basically introduced by Hamzavi et al. This WASI Vitiligo Area Scoring Index was, conceptually derived from the PASI. PASI means Psoriasis Area Scoring Index. So on the same pattern, psoriasis, we see how the parts of the body are involved, and the patch. Uh, this is measured by the palm of the patient. That means if one area is, this affected here. Suppose I will tell you, this my whole area is affected, and if this whole palm is, this affected over here, that means 1% of the patient is, 1% of their body, 1% of the body of the patient is involved. So likely, similarly, this is the, this Vitiligo area scoring index is calculated using a formula that includes contributions from all body regions, possible range 0 to 100. This is VASI is equal to summation of hand units into residual pigmentation. So let us go see. This is Vitiligo area scoring index. 100%. When we call the patient is 100% affected. When there is no pigmentation anywhere in the body, when there is no pigmentation anywhere in the body, that means the patient is 100% affected. 90% means specks of pigment. Suppose these are specks of the pigment. These are the specks of the pigment, this area. So once this area, so when their specks of the pigment is there, that means 90% of patient is affected. 75%, the depigmented area exceeds the pigmented area. That means when depigmented area exceeds the pigmented area. When depigmented, see, this depigmented area is affected, exceeds the pigmented area. See, these are hypopigmented areas. There are all these specks of these. So this 75 we call here as 75%. 50% means 50-50, means half of the color of the body is preserved and half is gone. So there we will say the 50% is involved and 50% is preserved. That means 50% of the patient body surface of the patient is involved. 25 means just like this 75%. Here the pigmented area exceeds the depigmented area. In 75%, depigmented area exceeds. Here pigmented area exceeds then depigmented area. and 10% means only specks of depigmentation. Like 90% specks of pigment is there, here specks of the depigmentation, like this, specks of the depigmentation, that is, this is 10%. This is how we measure, and this is a very, I mean, it is not easy to make you understand in few minutes. This is also, let us not go. This is, now let us go to the case study. This is my, I mean, this was my one of the case which I have treated at National Institute of Homeopathy. And this case was, the patient was, he was from Maniktala. This was a lady. Uh, she was around, 55 years of age. She had multiple, I mean, hypopigmented spots, depigmented patches scattered over whole body, including forehead, since 5 years. She had history of measles in childhood and recurrent attacks of respiratory tract infection in childhood. No significant family history related to vitiligo. She was being treated by modern medicine but did not find any result. Then she landed up here in NIH on above mentioned date. Case taking was done and the case was repertorized. After analysis and evaluation, following symptoms were taken into consideration of the repertorization. That is what I was telling you in the previous slide, why repertorization is important. See, in this case, when this case was repertorized, the first medicine was calcarea carb, second was sepia, third was sulfur, fourth was lycopodium, and fifth was kali carb, as per the repertorization. But what I did, see, sulfur has covered, matlab, I mean, 8 symptoms and the score was 18. Sepia 7 symptoms and the score was 17. Sulfur 7 symptoms and the score was 17. uh, I prescribed sulfur. Do you know why I prescribed sulfur? The intensity of the symptoms, i means I mean the symptoms which we see: company desire, stomach desires, stomach disordered, extremities perspiration, waking difficult, constipation. I mean, the important symptoms of the patient where the intensity was more was covered by sulfur. So on first instance, I gave sulfur, and there was another reason. Suppose if sulfur fails, then I had a, as per the materia medica, if we go through the complementaries, sulfur is being followed by calcarea carb, and calcarea carb is being lycopodium. So what if there would have been failure by sulfur, then I would have easily gone to calcarea carb. If calcarea carb I would have prescribed on the first instance, it has failed, then I could not have gone to prescribe sulfur. So the first medicine I gave was sulfur. The reason was sulfur is being the complementary of the sulfur is being followed by calcarea carb, and calcarea carb is being followed by the lycopodium. So I thought, let us go with sulfur. And when I gave sulfur, there was a tremendous response. From 202 doses were given. This is the case. This is the case. You will see how much this area was involved. And this is, after 3 months, see how much this patch is recovered. And see this, the pigmentation, normal pigmentation has there. See, so this is after 3 months, and this is after 6 months. This was a one of the case. And see the another case is also of this lady, another few images. See the involvement of this arms. See, and this is on after 3 months, and this is after 6 7 months. See, there is complete repigmentation. this complete repigmentation. Still, some depigmented spots are there, but if we'll assess it through the Vasi area scoring index, this I mean sort of scale, then this lady has got a significant improvement. If we will assess it through Vasi, this vitiligo area scoring index scale, then this we can say this lady has got a significant improvement. See, and then there is another case. See how much body surface is involved. See the above and below eyes. See the second, how much has recovered. And see here and here. This is almost fully recovered. And this child, I prescribed this child Cistus canadensis. Do you know on what basis I prescribed Cistus canadensis? This patient has a strong desire for cheese. And if you will repertorize, if you will open up Kant's repertory, and Cistus canadensis is second grade medicine. Plus, this patient had there was cold intolerance. This patient had constipation. So all these symptoms were going towards Cistus canadensis. Here, I should say I did a keynote prescription. I press this consult this Kant's repertory, but here I did a keynote prescription, and by keynote prescription I got these results. And later on, I don't have those images with me. Around I think 95%, 96% this patient was recovered. This was that was the tremendous result. By later on, I changed the medicine on different visits on the basis of the symptom similarity, on the basis of the changeability of the symptoms. But the initially I prescribed Cistus canadensis on the basis of strong desire for cheese. There was cold intolerance. The patient had strong constipation. So I did a keynote prescription over here and got. Later on, I prescribed tuberculinum. Later on, I prescribed calcarea carb to complete the cure of this patient. But initially, Cistus canadensis has done wonderful job. So see the back of this same patient. See, almost recovered. Then there is case number 3. See this beautiful girl. She had vitiligo patches around eyes, around neck. See, she has regained this pigmentation back. She has regained pigmentation back. And there was, at the time of when I left NIH, she had many depigmented patches, but she recovered significantly if we will assess through Vasi scale. As per the Vasi scale, this patient has, recovered significantly. In this patient, I have prescribed sepia. The symptoms were, I think so. In this case 3 patient, namely TM registration number address, came to NIH and present with a depigment patch over face, around eyes, neck and arms. There was strong desire for meat, salty things, and the patient had history of delayed milestone in childhood. Sorry, calcarea phos was given. Was prescribed in LM potency up to LM 12, followed by tuberculinum 202 doses, and again followed by calcarea phos in LM potency. So on this child, that this beautiful girl had a strong desire for meat, salty things. A patient had a history of delayed milestones in childhood. So on repertorization, this calcarea phos was given in LM potency up to 12, followed by tuberculinum 200 dose, and again followed by calcarea phos in LM potency. This is another case. See their hypopigmented patch and see how much she has regained. This patient had a this is also an interesting case. She had a I mean, this I think whole of the scalp has got involved by this hypopigment vitiligo. So again, this beautiful child was prescribed Cistus canadensis on the same this similar symptoms which I prescribed in the previous one. She had also strong desire for cheese, and there was tendency to catching cold easily, and there was a strong constipation. I mean, the patient had a this child had a chronic constipation. So this was again given. I mean, this Cistus canadensis, and this patient has, I mean, responded in few weeks only. See, the whole scalp is now has regained its color back. See, this is the normal color of the scalp. See the hypopigmentation of this. Yeah, this is the same. This is the same girl, and she got cured in, I think 2 months, less than 2 months. See this. This is a segmental type of vitiligo. Here, this patient has recovered. Not that much, but I told you already. This segmental type of vitiligo is very difficult to cure. See, this as per the Wasi scale, this has a significant improvement. This has, I think, more than 60%. This patch is, I mean, recovered, cured. This lady had hypopigmented spots here. See, see this. She has regained back its. So there are these are I have many pictures with me. Those patients who have got significant improvement. So I have only shown you few slides. So this is conclusion. Believe and achieve possibly only when you work out a when you work out a case on the basis of the totality of the symptoms and individualization. The outcome of the case depends upon the severity, chronicity, and the type of vitiligo. There is definitely a positive role of homeopathy in vitiligo where repigmentation is possible. A large number of studies based on convincing evidence-based parameters, including validated skills, are essential requirements to document the usefulness of the homeopathy. So thank you very much. This is references. At the end, the World Vitiligo Day is observed on June 25. This day is, I mean, the day when Michael Jackson was, when she left this world. She left on 25th of, I mean, June in 2011. So that day is, I mean, observed as the Vitiligo Day because she had developed vitiligo patches in the past, and she had, I mean, in 80s until his death, which occurred on June 25, 2009. The main event of the first World Vitiligo Day occurred at Silver Bird Galleria Artrum in Lagos, Nigeria, with the participation of the several volunteers with different experiences: dermatologists, motivational speakers, dancers, artists, comedians, uh, patients, united by the common will of the spreading knowledge and awareness about vitiligo. Simultaneously, other events took place in other parts of the world organized by the local associations. So thank you very much. This is from my side. Thank you very much.
Thank you, Dr. Ghulam. We get more matured Ghulam, what we see in the night. And Ghulam marvelously describe all the parts of vitiligo with etiopathogenesis, clinical classification, differential diagnosis, with homeopathic approach, with repertorial approach, with his own cases. And it is nothing to see, tell about the Dr. Ghulam. He described all the vitiligo in details. So, though it is a very difficult, vitiligo is a very difficult cases, and he described also in details. And we also teach from Dr. Ghulam. Whatever I read from other books in dermatology, he gives in details. Not even you get the dermatology books also. So vividly described also in his repertorial approach and Anvinian approach to treat the vitiligo and its improvement. So next, thank you, Dr. Ghulam, and thanks to Bidyut. Next to Dr. Kalyani sir, our teachers, to tell something. Dr. Kalyani sir.
Thank you, Dr. Sarkar, for nicely moderating the session. Many thanks to our Mousumi for coming with us and presenting his library status and condition of the library. Especially participation of Department of Library to the CME is a new approach, and that all thanks goes to Dr. Bidyut Mukherjee. Equally thanks to all the viewers, those who are observing the CME, and special thank to today's brilliant speakers. First, Dr. Taha for nicely presenting management of acute situation of a very crucial disease. We know that people are afraid of bleeding. That's why all red signals, all red colors has been rather blamed as seriousness, dangerous things. So people get afraid of bleeding from anywhere, especially from an area where there is stool passes out and there is no chance of other any bleeding spots. People become very hurry and tense and anxious to stop bleeding immediately. Dr. Khan has nicely explained acute measures to stop bleeding and pain as quick as possible to gain confidence. But we must assure that these piles, whether it is bleeding or non-bleeding, are the manifestation of some other disease. This is the outward manifestation. Either the disease in the liver, or in your portal vein, or in the bone marrow, or in the heredity, or in the bowel motion, means digestion, assimilation, etc. So the cause lies somewhere else than rectum and anus. So after getting relief of this bleeding and pain, we should not try to think of constitutional drugs, because by giving palliative drugs, many symptoms goes off. After relief of the pain and bleeding, to assimilate uncommon symptoms become difficult. That's why, along with treating the bleeding and pain, we must concentrate very critically for homeopathic generalities, because just after completion of the bleeding and pain, we should think of the constitutional drug, that means the drug for the cause of the manifestation, bleeding and piles. To treat those diseases, constitutional medicine is the best way out. Usually what patients do, when the bleeding and pain goes off, patient goes out of our hand, they don't report back. They don't feel that further treatment with improvement is very much necessary. We have to guide them that by this medicine your pain and bleeding has gone, but disease is remaining as before. Any moment there may be relapse. So please do not stop treatment until I tell you, means until I find the cause of the manifestations are off or cured. That's why with the treatment of the complaints, presenting complaints, we must ask the patient to continue the treatment until I will tell you to stop medicine, means until I am confirmed of curing of the source of the disease, cause of the bleeding and piles. So anyway, beautifully he has explained how to tackle immediately to gain confidence of the patient and to improve homeopathic emergency system of medicine. Thank you, guys. And I'm very much thankful to Dr. Ghulam Nabi Wani. Nicely, he presented very nicely, very details regarding vitiligo and presented documented cases. We must be very sure, as Dr. Sarkar told us, that all these details are not available in literature too. That is a very good help to us gaining literal information. But it is more useful, more you are encouraged by seeing the improvements. That will practical presentation of homeopathic improvements are more encouraging than theoretical information. So many thanks, Ghulam, and we all must request him to carry on this presentation, means documentation and then presentation to us, by which all of us will be encouraged, and especially by assessing or by following the exact measures of homeopathy: case taking, evaluation, repertorization, mathematical analysis, then prescription, without ignoring any system of prescription. That means even keynote prescription is the case is very clear cut by keynote symptoms, then definitely your keynote prescription also can cure the disease. So anyway, today's seminar is definitely very much informative and documented seminar. All of us, we are encouraged and helped by these seminars. Thank you very much, all the speakers, viewers, and especially Dr. Bidyut Mukherjee and his son Orku Mukherjee. Orku is taking maximum strain for his father and fatherly uncle and like us. We are really grateful to him. He's a little boy, students of third year, but helping us like anything. We pray to Almighty that he must grow up and be a very prominent and promising homeopath. Thank you very much. Thank you all.
Thank you, sir. There is one question from Dr. Ujjal Mondol to Dr. Taha Khan. Dr. Taha, please be on screen. Dr. Taha, would you advise medicinal treatment for third degree and fourth degree piles?
Yeah, I've read the comment. Actually, Dr. Ujjal, see, you cannot treat or provide medicines to the patient based on the degree of piles. That simply you have to see whatever the degree it, be it third degree, be it fourth degree piles, however the severe the case of piles is. But you need to find out what are the symptoms that are the patient is giving at that degree. So if means in general pathology, whatever we have discussed and whatever we know that third degree piles might have prolapse, fourth degree piles might have prolapse, there might be pain. But at the end of the day, the symptoms that the patient is giving, that is the only thing that is guiding us to give the give the remedy to the patient. So whatever the patient is saying, like third degree, fourth degree piles is okay to make the patient understand how severe is the disease, what the patient is suffering from, to tell the patient that he has come to the right hand, that the doctor is knowledgeable. It's not like the patient knows about the first degree, third degree, fourth degree and all the degrees of piles, and the doctor is unaware the piles has 4 degrees. So that is okay to make the patient at least understand and satisfy that he has come to a knowledgeable doctor. But we as a doctor know degree of pile doesn't matter. Whatever the patient symptom that the patient is giving is the only ultimate thing that is we are gonna take, and based on that we are gonna prescribe. So I hope that is clear to you, Dr. Ujjal Mandal.
Bidyut, I like to add
Thank
a
you,
little
Dr.
more.
Taha.
Yes. Bidyut, I like to add a little more because Ghulam has asked what we should do to all the patients. We should not bother about the degrees, because the degrees depend on many factors. Whether the patient was maltreated or ill-treated or manhandled, we do not know. So that if we find the condition is improving gradually, following the Herring's law of cure, we should not ask the patient that homeopathy cannot cure or you go to the surgery. We will refer the cases definitely when absolutely fails in spite of all our efforts. We can tell the patient that I will try for a few days. If I find this type of improvement as per Herring's law of cure, then I will tell you after a few days or few months whether it will be cured by me or you have to go for surgery. If you get improvement within few days or 1-2 months, expected improvements as per Herring's law of cure, then patient also get confidence that as doctor told before treatment, exactly the things are happening one by one. So we can safely wait. That will increase the confidence of the patient and us too. For all the cases, it has been told by our Organon of medicine that it is a pseudo-surgical case. So until the case cries for surgery, we should not immediately refer the cases to surgery without any trial. Thank you very much. Please.
Sorry. Thank you, sir. And we are really encouraged by the live viewers who had been patient enough to uh, listen to our discussions. The number is now 99, and I think it will swell after a few weeks once the recorded version goes online. And with this, thanking all of us on the screen, I'll return to the Orko Mukherjee, our backstage editor, to close the session. Over to you, Orko.
Thank you, Bidyut.
Thank you all. Thanks for watching. I hope you have enjoyed today's CME. And if not, it's not a matter of fact. Just go check out with the other check out. We have done other CMEs too. Just subscribe our channel for more upcoming CMEs which we are having on every month, like two CMEs every month. So go check it out. Go check our channel. Do make sure to subscribe and press the notification bell to get updated as fast as possible. And also we are on Telegram, so go check out the Telegram and go join our Telegram channel. The link is in the description below. And also like us on Facebook, Instagram, and Twitter. Like on Facebook and follow us on Instagram and Twitter. Uh, we will be very happy to have you with us. And over there, we too also give knowledge and information about day-to-day updates on NIS alumni and other stuffs related with homeopathy. So and with this, I'm leaving. Good night. Bye.